we now throw open the discussion. So we can take some audience questions. Dr. Senapati, the first question that has come in is, the person writes about her endometriosis, right? Since I like to, so she says, I live every day feeling like a robot, forcing myself through the motions because endometriosis, adenomyosis, and fibroids have destroyed anything inside of me that was human. And then she explains about her treatments. I'm just going to cut this short. But her question is, what is the medical research community doing for women like me, and can I expect something more than just being told to take 1200 mg of ibuprofen down 3 times a day and deal with it? So in other words, maybe you could talk a little bit about latest research that's happening in the field.
Sure. Yeah, this sounds like a tough situation. And you know, one thing that I can tell you is there's definitely a lot of interest in the medical community in making things better for patients with endometriosis, and recognizing that while we've come a long way, we still have a long way to go. So some of the treatments that have been explored are other types of medications that either act at the level of the brain, so things like gonadotropin-releasing antagonists, or that act kind of directly at the level of the individual kind of endometriotic lesions or implants, so things like progesterone receptor modulators are being studied, and there was actually, there's some interesting things that are coming out of the basic science research as well, and some mouse models that have looked at different components that are produced more commonly in patients with endometriosis, that like galectin-3, that can be linked to inflammation and the formation of new blood vessels and fibrosis, and all of the things that cause some of these the symptoms that patients experience. It takes some time to get things from sort of the bench to the bedside, but people are definitely very interested in this and continuing to work on this. And there's clinical trials all over the U.S. for some of these newer agents. So what I will say is, I hear your frustrations, and we are working on it to the best of our ability.
Thank you, Doctor. We'll take another question which says, what are some of the precautions that women with endometriosis need to take while trying to conceive?
Okay. So that's a great question. I think that one of the things to be aware of is that, for one, there's some women who, do okay when they're off of medical management as they're trying to conceive. Others will notice that their symptoms get progressively worse. So I think, working with your healthcare provider and sort of setting timelines and goals and points of reassessment are very important. So, as I had mentioned previously, I usually tell people try about 6 months, and if you're not pregnant in that time frame, that's a good time frame to at least start the conversation with a fertility specialist. I think it's also important to know that many women with endometriosis, their fallopian tubes can be affected, which may put them at an increased risk of ectopic pregnancy, or a pregnancy that could implant outside the uterus. So in women that have endometriosis, I always advise them that if you do get pregnant, it's important that you see a healthcare provider as soon as you know, so that they can, so that he or she can reassure you that the pregnancy has implanted in the right place, and that things are looking appropriate moving forward. So I think those are the 2 most important pieces of advice that I can give.
Thank you, Doctor. We have another question which says, if you have decided to do egg freezing at 34, 35 and are a few years off trying to conceive, but symptoms are highly suspicious of endometriosis, is it better to postpone a laparoscopy until ready to conceive, or best to investigate now to confirm a diagnosis and excise any endometriosis is found? she wants to know what are the risks of waiting.
Sure. So, I think the decision to consider surgery is one that it warrants a conversation between the patient and the surgeon. And some of the factors that go into deciding when to do surgery have to do with the patient's medical condition overall. So, other medical problems, prior surgical history, other things that might be going on in someone's medical life. But I think also most importantly, the symptoms. So, I usually guide patients on whether or not to consider surgery based on the severity of symptoms. And if this is a situation where, someone says, I feel like my periods are getting worse, or I feel like I'm having more pain over time, I think it's better to look sooner, both for diagnostic purposes as well as for therapeutic purposes. Even if one does not anticipate getting pregnant in the short term, I think from the perspective of kind of knowing, what we're dealing with, what's the cause of pain, because, endometriosis is one cause, there may be others, but also potentially addressing it moving forward. So, for example, if a patient comes to me and says that I'm not quite ready to have a family yet, but I've noticed more discomfort, we do a laparoscopy, diagnose and treat endometriosis, that may be a scenario in which I advise to consider hormonal management like a birth control pill or an IUD until she is ready to have a family, as opposed to not being on any medication, and then there's a greater chance that her symptoms may recur in that setting. So I think it's a dynamic discussion, but it's often driven most by the symptoms that the patient is experiencing.
Okay, we have a couple of 2 minutes, so maybe we can just take 2 more questions. The next one is, how is stage of endometriosis related to infertility? So, which means, I think she wants to know, do women with very severe endo always suffer from infertility and vice versa? Or do women with the mild endo have lower rates of infertility?
So it's a great question, and endometriosis is one of those tricky diseases that both from a pain perspective as well as an infertility perspective, the stage of disease, which is something that is classified at the time of surgery, does not necessarily correlate with fertility or with symptoms in general. Now, at the time of surgery, if, for example, there is a concern that both fallopian tubes have been impacted, then that's a scenario in which that particular presentation may be much more likely to lead to infertility. And so, I think that it's important for women to be aware that, even stage 1 infertility can cause, or stage 1 endometriosis can cause infertility, but having had a history of stage 4 infertility or stage 4 endometriosis does not automatically mean that you cannot get pregnant. And so I think the flip side of this conversation is, don't assume if you have endometriosis it's impossible for you to get pregnant. If it's not a good time in your life to be building a family, make sure that you're using contraception, etc. But the opposite side of that is, if you are someone who has endometriosis and it has taken 6 months to a year to get pregnant, irrespective of what stage of disease you were told that you may have, that is a scenario in which you should see a fertility specialist.